Alrighty, hello everybody. So this is gonna be the third part of the Pharm review, going over drugs for the anticoagulation and your cholesterol lowering drugs. So without further ado, we're gonna go ahead and jump right into it. Okay. So we're first going to let's start with magnesium elimination in the body. So, magnesium is excreted through your kidneys, and it may take in larger amounts when a loop diuretic is used because loop diuretics don't allow for sodium, calcium, potassium, magnesium to be reabsorbed, meaning they're going to be going out as pee. They're going to be going out as pee. So that's how magnesium is eliminated in the body. So your statins were next. So statins are like atorvastatin, orvastatin. All your statins are going to be these HMG-CoA reductase inhibitors. So your statins are most effective in lowering LDL and elevating HDL, reducing your triglyceride levels as well. They also have cardiac benefits that promote plaque stability or less growth, reducing the risk for cardiovascular events and increasing bone formation. So these medications are good because they're going to lower that cholesterol and elevate the good ones that we want. With any of our cholesterol medications, we must give these medications once a day at night or with like the evening meal. Because we give this at this time because it's going to mimic the body's production of calcium, which is natural. And with these medications, we want to increase that cholesterol. Some adverse effects with with your statins are going to be headache, rash, GI effects. Some of those rare effects are going to be myopathy or rhabdomyolysis, which is your muscle breakdown, which you may also have liver toxicity, new onset diabetes, and cataracts for older patients. So we must be very careful with this medication with your diabetics and older people. Do not use lipid lowering drugs in pregnancy because they can be teratogenic. No grapefruit juice with your statins because they interact with that CYP344 gene. So myopathy is going to be that enlargement, and rhabdomyolysis is going to be that muscle breakdown. Concurrent use of colostelium and insulin. So colostelium is a bile acid sequestrant that binds with bile in the gut, preventing absorption. This drug can be used as adjunct therapy in those with type 2 diabetics and insulin in hyperglycemia. So this is very good. Again, lovastatin patient education, remember at night, once a day. And we want to make sure that we know that the risk of myopathy and that rhabdomyolysis, and to always notify the provider if the muscle pain occurs, because bone pain is very prominent. Okay. More education. Remember, it might take a couple weeks to see lipid level changes. Remember, you should always maintain a diet and exercise while using lipid lowering drugs. You should always have a lipid plasma test twice a year. That's like fasting. Remember to screen every 5 years or every so often. Remember, at night or in the evening meals is when you should be taking this medication. Stress reduction is needed. They need to stop smoking because that can cause plaque buildup. Remember that TLC diet, low cholesterol and fat. You should always use lifestyle modifications first, and if those are not doing well, you can use medications. For cholestyramine, which is another bile acid sequestrant, you should always dilute the medication and dilute the fluid in water and drink. Most of these lipid-lowering medications are going to require a full glass of water with administration. And those were your lipid-lowering meds. Now we're going to talk about hemophilia. So hemophilia is when there is a lack of certain factors in the body. And because of that, certain bleeding disorders can occur. So, our primary treatment with hemophilia A and B is to replace those factors. So, hemophilia A focuses on that factor 8, and we're going to need factor VIII therapy with these medication with this disorder. So we can give this in plasma or recumbent. Some of our adverse effects from factor VIII therapy is those allergy symptoms that are induced by the medication, such as hives, stuffy nose, and fever. You can treat it with Benadryl. Desmopressin is also used to help stop or prevent bleeding. With hemophilia B, they're going to use factor IX therapy, which is just similar to factor VIII, but it's going to work on those factor IX receptors. Alrighty, now we're going to go into heparin. So, heparin works to inhibit action or formation of clotting factors. It prevents a clot from forming. They do not have a direct effect on a blood clot that's already formed, meaning these are not clotbuster medications. Heparin is used for procedures where anticoagulation is required. They may use it for pulmonary embolism, strokes, DVT, open heart surgery, renal dialysis, DIC. You can use unfractioned or low molecular weight heparin. It can be IV, PO, sub-Q. IV and sub-Q. Adverse effects of any of your heparin medications is you're going to have potential for bleeding. Heparin-induced thrombocytopenia, meaning they're going to have low platelet or white blood cell counts and allergic reactions. You should always monitor your patient on heparin therapy for bleeding, low platelet or low white blood cell counts, and the blood levels of the drug. So IV pump or sub-Q is how it should be given. Your labs are going to be key when monitoring your heparin level, monitoring heparin. So you're going to monitor with heparin APTT. So APTT kind of looks like that TT part that kind of looks like an H. So APTT should be between 60 to 80. So maybe we see that a patient's APTT is 40. So if it's less than 60, we will increase the dose of that heparin. If it's greater than 80, for example, maybe it's 100, we're going to decrease the medication dose. The antidote to heparin is protamine sulfate. So you must know the antidote because we want to make sure that the patient doesn't go toxic on us or if we need something to reverse the heparin. So we want to know our vital signs in our bleeding patient. So if we ever have a patient that's bleeding, we're going to see that low blood pressure, high heart rate, and high respiratory rate. So we must know the vital signs, which are going to be key to indicate if there's bleeding somewhere. Alrighty. Next we have warfarin. So warfarin is very similar to heparin, but it works in a different way. So warfarin is used for inhibiting clotting factors and to prevent DVTs long term. It works long term and it may begin 3 to 4 days after being given. You will need to hold the medication 5 days prior to surgery. Some adverse effects of warfarin are hemorrhage, which is bleeding, teratogenesis during pregnancy, meaning a pregnant woman should not take this medication if they plan to get pregnant or are pregnant, and then purple toes, probably because of that bleeding. Administration, it's going to be by mouth in the evening, same time each day, with or without food. Our labs that we will monitor with warfarin use are PT and INR. So we need to make sure that that PT level is in that therapeutic range and that the INR is in that therapeutic range as well. And we also need to monitor for bleeding, of course. We went over those bleeding vital signs just a minute ago. Remember, low blood pressure, high heart rate, high respiratory rate. INR should be between 2 and 3. And if INR is less than 2, we're going to increase that warfarin dose. If it's greater than 3, we're going to decrease that dose. Warfarin interacts with any drug that increases anticoagulant effects for blood thinners. Drugs that promote bleeding, decrease anticoagulant effects, heparin, aspirin, acetaminophen, because these drugs may induce bleeding, and we do not want that. Our antidote is going to be vitamin K. And some foods that are rich in vitamin K are mayo, canola oil, soybean oil, and green leafy vegetables. Heparin and warfarin's mechanism of action. So we kind of went over this a little bit already. So heparin works to inhibit the action of formation of clotting factors. It prevents clots from forming, but they do not have any direct on an effect of a blood clot that's already formed. Warfarin is used for inhibiting clotting factors and to prevent DVTs long term. Now we're going to jump into iron therapy. So iron therapy is used when a patient has low iron levels or is not getting enough iron from the diet, they're pregnant, or they're bleeding. There's many different forms that we can give of iron. We can give salts, we can give dextran, many different things. Some of our adverse effects we must teach our patients before giving the med is they may feel some GI effects and staining of the teeth, which can degrade from their appearance. So we need to teach that this may occur. They also may taste a metallic taste because iron is metal. Some toxicities, signs and symptoms of toxicity are nausea, vomiting, diarrhea, shock, acidosis, gastric necrosis, hepatic failure, pulmonary edema, and vasomotor collapse. Iron interacts with antacids, tetracycline, and ascorbic acids, meaning we must take these medications 1 hour apart. You should always administer IV iron in a large filter with a large IV. You want to teach the patient to expect the iron solution to be black and thick. We need to teach about the potential for black stool with an iron infusion so that when the patient does actually go to the bathroom and they see it's black stool, they're not going to freak out. Always teach before you give the patient the medication about what will happen. Lab values to monitor for bleeding and anemia. So, when we look at bleeding, our vital signs, we're going to have that low blood pressure, high heart rate, and high respiratory rate. Our red blood cell count is actually going to be lower than 4.7, meaning there's not enough circulating red blood cells in the body. Our hemoglobin will be lower than 12, and our hematocrit will be higher than 52, because when somebody's bleeding, there's more body that the blood cells have to cover, meaning that hematocrit is going to be higher. So anemia is based on various causes. For example, pernicious anemia, low vitamin B12, maybe they have sickle cell anemia. But it's due to having many different causes, but one common feature is that they may have small, pale, red blood cells. They may need more of a certain vitamin. Maybe they need to take vitamin B12 shots or anything. Maybe their bloods are being damaged in some way, and we need to give them a blood transfusion. Often, we want to make sure we treat the cause first before we start doing anything invasive, because blood transfusions require a lot of consent and a lot of pre-op kind of things before we give it. Next, we're going to move on to filgrastim. So filgrastim is used to stimulate white blood cell production. It reduces severe neutropenia and reduces the need for infection, hospitalization, and IV antibiotics. We are going to often use filgrastim with cancer patients due to immune suppression. Often with our cancer patients, they're going to have low white blood cell production or low neutrophil counts. And this is going to help stimulate that count. One adverse effect that we must know about is bone pain with filgrastim. We also need to know about leukocytosis. If these adverse effects occur, you must give acetaminophen or decrease the med dosage. Dabigatran. So dabigatran is a direct thrombin inhibitor that directly prevents clots from forming. It treats atrial fibrillation, prevents blood clots prior to surgery, and prevents blood clots, period. Some bleeding, some problems that we may run into is bleeding and dyspepsia, which dyspepsia is going to be like that belching. You can give it with or without food by mouth. Remember, you don't have to monitor anticoagulation with dabigatran. There's going to be little risk of adverse events, and the same dose can be used for all patients regardless of age or weight. There's no antidote for bleeding related to this medication, so if they do bleed, that's a problem. Rivaroxaban and bleeding precautions. Rivaroxaban is an oral anticoagulant that causes inhibition of factor XA. It works fast, has a fixed dosage, lower bleeding risk, fewer drug interactions, and no need for monitoring. It's intended for prevention of DVT or PE, prevention of stroke in PE or AFib patients. So an adverse effect is going to be bleeding, which may occur at any site at any time. They're going to have an increase with any drug that impedes that hemostasis or impedes clotting. There's no antidote to reverse the drug, so you must use activated charcoal. Now we're going to go over bleeding precautions and signs and symptoms of bleeding, because you must know this to be able to accurately assess your patient and to give them the medication and to ensure that they do not bleed anymore. So, our signs and symptoms of bleeding are going to be, you're going to have petechiae, ecchymosis or bruising, black tarry stool, coffee ground emesis. You may even have frank blood in the vomit, depending on where the bleeding is in the body. Bleeding out of unusual places such as the eyes or nose or ears. Well, maybe not nose, but the eyes and the ears. Hematuria, which is blood in the urine. Tachycardia or hypotension. So, some of the bleeding precautions we will need to educate our patients on is they must use a soft bristle toothbrush, because hard bristle toothbrushes can actually break the gum line, causing one to bleed. We must teach them to be gentle when brushing their teeth as well, because hard, vigorous scrubbing may actually cause bleeding. They'll need an electric razor so that they don't nick themselves when they're shaving and cause them to bleed. They must wear good-soled shoes so they don't step on anything that may make them bleed. Have a safe environment, because if they fall down, they could bleed. Wear a medical alert bracelet. Do not strain while on the toilet. No contact sports, because they could bleed. Decrease of invasiveness of procedures such as needle sticks. Maybe if they're a diabetic, they can go to maybe a pump or a electronic method of monitoring. They may need to blow nose gently, because they don't want to break any of those capillaries. And we must observe for signs and symptoms of bleeding and teach the patient what they need to see, what they may see that may be bleeding. Alrighty. Here are some common lab values. So remember, potassium level, 3.5 to 5. Above 5, give K wasting diuretic. Lower than 5, give K sparing. Assess tele with all the patients with K levels due to arrhythmias. Sodium, 1.35 to 1.45. Remember your kidney labs. You have to see if your kidneys are functioning and can tolerate drug effects. Remember your BUN, 7 to 20. Creatinine, 0.8 to 1.4. Spectrogravity, 1.5 to 1.3, basically. It can also tell us if they're dehydrated or in overload. And we also need to know this to see if their kidneys are working correctly, so we can eliminate drugs after they've been metabolized. Red blood cells should be between 4.7 and 6.1. Low red blood cell levels mean that there's anemia or bleeding someplace. White blood cells, 5,000 to 10,000. Remember, low counts may mean risk for infection or immunosuppression. High count means that there may be an active infection. Platelet levels, 150,000 to 450,000. Lower levels means that there's an increased risk for bleeding. H&H, 12 to 18 or 37 to 52. Triglycerides, less than 150. HDLs, less than 40. Remember, if any of your cholesterol labs, remember they have to have good physical activity that can bring them up or bring them down. Digoxin therapeutic level is going to be 0.5 to 2.0. APTT level with heparin is 60 to 80. Less than 60 means we're going to increase the heparin dose. More than 80 means we're going to decrease the heparin dose. PT and INR. So if your INR, so PT to INR, 18 to 24 or 2 to 3. Less than 2 for your INR, you're going to need to increase that drug dose. And if it's more than 3, you're going to decrease that drug dose of the warfarin. Okay? And this concludes part 3 of the pharmacology review. If there are any questions, please let me know. Otherwise, good luck on your test.